so that's a very compelling argument to me for starting early, and I wouldn't have thought so, but it just worked out that way. Do you have thoughts on that study?
I think you're absolutely right, and when you think about it, that was not an ideal group to start treatment with. They had established MS 7 years or so. They often had disability. I think that really gives some credence to really treatment being able to show a meaningful effect, and I think we will be able to show it in our generation. It's not easy, it will take time, and you need large numbers of patients.
How can we do it better?
You know, I think payers have really taken a similar view. You know, we've looked at the studies as well, and we realize that, you know, it's going to take a long time and probably a lot more experience than we have to ultimately, you know, show what the total impact of treating MS is. On the other hand, we've taken the studies as they are and agree. I mean, that's what we do by covering the treatments. You know, we believe the studies. We believe that there is beneficial impact of treating patients with appropriate agents. You know, we have in general lined up and supported the concept of treating clinically isolated syndrome as well. And we too are looking for those same data. Ours is a little different view. We're looking at it, you know, on large population basis to be able to demonstrate to our customers ultimately who ask the question, you know, what do I get for this expenditure? And many times we can't answer that question and just say that we, you know, the data does show improved outcomes, improved quality of life, perhaps less progression in patients to disability, and you know, it's the right approach medically, and that's the value you get when we're using your resources.
Just another, and you probably both would want to comment on it. Some of the other things that we do have to talk a lot about at our Pharmacy and Therapeutics Committee meetings when we discuss the therapy for multiple sclerosis. First of all is the use of guidelines, because a lot of times when there's a national guidelines, diabetes, hypertension, hepatitis C, you know, other kinds of guidelines, that in the case of multiple sclerosis right now, there was not a real defined guideline. You can have, you know, different physicians have different ideas on which medications that they actually like to use. So, and I'm not sure there still is a guideline yet, although we would love to see some sort of, you know, guideline that would say this is, you know, this is a good practice. The second part, and this we do grapple with a lot, is when does a patient come off therapy? And again, not the only disease we talk about this with, Alzheimer's disease. We talk about this with all the time. But we see a patient who, as you say, 12, 15 years, they're walking in, and then they walk into the clinic and they have a cane, and then a bit later they walk in, they're in a wheelchair, and then they're not walking in anymore. But do we still treat through it? So those are some of the things that we grapple with also with our neurologists.